Hi, I am Dr. Selvaraj, Professor of Surgery, Malacca Manipal Medical College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to listen these videos over and over again. In this episode, I am going to talk one of the important causes for obstructive jaundice, the choledocholithiasis. So I am going to discuss under the following subheadings. I am going to discuss the various causes of obstructive jaundice, and then a classical clinical vignette I am going to discuss. Then I will be talking on the etiopathogenesis, clinical features and complications, investigations and treatment of choledocholithiasis. I have also included a mind map and a diagnostic algorithm and a management algorithm on choledocholithiasis. So what are the various causes for obstructive jaundice? It can be divided into intraluminal causes, mural causes and the extrinsic causes. The intraluminal causes are choledocholithiasis, that is stone inside the bile duct, and parasitic infestations like Clonorchis sinensis, Ascariasis and schistosomiasis. The mural causes are malignant stricture in the wall, that is cholangiocarcinoma, or benign strictures following any post-inflammatory or post-operative or post-radiotherapy problem that can cause benign stricture. Even sclerosing cholangitis can also cause benign stricture of the extrahepatic biliary radicals. The extrinsic causes are carcinoma of head of the pancreas, periampullary carcinoma, pancreatitis, duodenal carcinoma, and lymph node in the hilum of the liver, that is the portal lymphadenopathy. So this is our classical clinical vignette. Our patient is a 40-year-old female present with a 24-hour history of right upper quadrant and epigastric pain associated with nausea and vomiting. She has had similar pain in the past, particularly after eating fatty foods. According to her family, over the last few hours, the patient has become slightly confused. Past medical history is negative. On examination, she is moderately tender in the right upper quadrant to deep palpation. She has slight scleral icterus. She has noted dark color urine. The remainder of her abdominal examination is negative. Vitals: BP is 90 by 60 millimeters of mercury, pulse rate 110 per minute, respiratory rate 16 per minute, and temperature 100 degrees Fahrenheit. So the laboratory examination, total WBC count is 15,000, total bilirubin 4 milligram, direct bilirubin 3 milligram, alkaline phosphatase is 350, normal is only up to 131, GGT is 330, the normal range is only up to 88. AST and ALT both are mildly elevated. Serum amylase is only 100 units. Urine is positive for bilirubin. So with this clinical finding, the patient presented with just 24-hour history of right upper quadrant and epigastric pain. There was similar history in the past after taking fatty food, and according to the family, the patient has become little bit confused recently. The past medical history is negative, but on examination there is tenderness in the right upper quadrant and there is a scleral icterus is present, and she has also have dark color urine. Her BP was 90 by 60, pulse rate is 110, respiratory rate 16, and temperature is 100 degree Fahrenheit. Laboratory, total WBC is 15,000, total bilirubin 4 milligram, direct is 3, alkaline phosphatase is increased 350, GGT is also increased, AST and ALT are mildly elevated, serum amylase is normal, urine is positive for bilirubin. So with these following clinical findings, your diagnosis is yes. Probably it is a case of choledocholithiasis associated with cholangitis. So what is choledocholithiasis? It is stones in the common bile duct or anywhere in the biliary tree. This can be divided into two broad categories. One is the primary stones that comprises only 5%. Most of these primary stones are brown pigment stones. They are formed in the CBD and biliary tree itself. Usually these are multiple, often sludge-like. Commonly these are either pigment stone or mixed type of stone. Usually this can also extend into the intrahepatic biliary radicals. Causes for the primary stone are biliary stasis, biliary dyskinesia, Herolis disease, that is intrahepatic choledocholcyst, and the choledocholcyst, Clenorchis sinensis, Ascariasis, etc. Whereas the secondary stone, this is the common variety, it comprises 95%. It can be either a cholesterol stone or black pigment stone. 15% of the gallstone will be having common bile duct stone also. 75% of the CBD stones are cholesterol stone, whereas 25% are pigment stones. So here you are seeing two pictures. Here you are seeing the secondary type where you are having stone in the gallbladder as well as in the common bile duct. This is the proximal part of the common bile duct. This is the distal part of the common bile duct. If it is in the distal part of the, the common bile duct, that is the common channel, usually the patient will also develop pancreatitis. This is the gallstone pancreatitis. Here you are seeing the stone is in the biliary tree, not only in the CBD, you are seeing it in the common hepatic duct, and even in the intrahepatic biliary radicals there are stones. Usually the common, primary stone in the common bile duct, or it is sludge-like. So what are the clinical features? Almost half of these patients, 50%, are asymptomatic, or they can present in a wide spectrum of clinical syndromes, namely biliary colic. It is manifest in pain in either the right hypochondrium and epigastrium, or these patients may be having evidence of jaundice, obstructive jaundice with dark color urine, clay color stool, and pruritus. Suppose if the stagnant bile has got secondarily infected, then the patient will develop what is called ascending cholangitis. Now the patient also will have fever, jaundice, and the biliary colic. This is the typical Chakas triad. This is characterized by this is the ascending cholangitis. Whereas if we are not going to intervene at the correct time, it will go for what is called suppurative cholangitis. Now the suppurative cholangitis also will be having altered mental status and the shock. Now it becomes 5 things. It is called Raynaud's phantom. During Chakas triad, okay, that is the ascending cholangitis, the stone may go proximally, it will start floating in the bile, and the jaundice may get relieved. That is why during this stage, during the ascending cholangitis stage, the fever, jaundice, and biliary colic will be intermittent. This is not persistent. Whereas in suppurative cholangitis stage, the pain, fever, jaundice, all are persistent one. And apart from that, the patient also will be having altered mental status and shock. And if the stone is in the distal CBD, then there will be features of acute pancreatitis. No, this is a chart where you are seeing if you have taken 100 patients with gallbladder stone, only 15 will be having common bile duct stone. Even among the 15 patients, 6 patients will be asymptomatic, whereas the other 9 patients will be having some symptoms, like maybe they will be having either biliary colic, jaundice, cholangitis, or pancreatitis. This is ascending cholangitis. The chances of suppurative cholangitis is very rare. If you are not going to do anything, then only the patient will go for suppurative cholangitis. All these syndromes can occur individually, or there will be a considerable amount of overlap So these syndromes will occur, manifest together in variable combination. So what are the patients also will be having either icteric and toxic with high fever and chills, or the patient may be perfectly healthy. The gallbladder usually is not palpable if it is due to CBD stone, because majority of this CBD stone is from the gallbladder. So if it is a gallbladder stone coming to the common bile duct, usually there will be repeated attack of cholecystitis, chronic cholecystitis. The gallbladder will get fibrous, so it got shrunken, so it cannot distend. This is explained by the law, Courvoisier's law. In a jaundice patient, if gallbladder is palpably enlarged, it is not due to gallstone. So indirectly they are saying it may be because of some other obstruction, like maybe see a head of the pancreas, periampullary carcinoma, or a stricture, benign stricture. There may be a tenderness in the right upper quadrant. It is not as marked as in acute cholecystitis, due perforation, or in acute pancreatitis. There may be an enlarged liver which is slightly tender. So the differential diagnosis include the other causes of obstructive jaundice, namely the carcinoma of the head of the pancreas, periampullary carcinoma, carcinoma of the biliary tree, that is cholangiocarcinoma, biliary stricture, the sclerosing cholangitis. Sometimes it may be intrahepatic cholestasis from drugs, pregnancy, chronic active hepatitis, or primary biliary cirrhosis. This is very difficult to distinguish from extrahepatic obstruction. However, you can do ERCP to make this difference. So what are the complications? Because of this obstruction, the bile proximal to that will become only the secretion of the bile duct, that is white bile, without any actual bilirubin. This is white bile, and because of this back pressure, the liver will go for biliary cirrhosis or hydrohepatosis. So ultimately there may be liver failure also. Sometimes the patient may go for the stagnant bile will be secondarily infected. Initially it is ascending cholangitis, then it will go for suppurative cholangitis. That will lead to liver abscess, septicemia. Sometimes if the CBD stone is in the distal part of the CBD, the patient also can develop pancreatitis. If it is the common bile duct stone, in the common bile duct stone can present with pain and raised bilirubin, or if it is cholangitis, there will be pain and there will be fever and also raised bilirubin. So investigation, lab investigation in cholangitis, there will be leukocytosis. 15,000 ml is usual, and values above 20,000 is also are very common. Total bilirubin level will be increased usually, but it remains under 10 milligram, and most are in the range of 2 to 4. Direct fraction exceeds the indirect one. Bilirubin levels do not ordinarily reach the high value seen in the malignant tumors because of the obstruction is usually incomplete and transient. In fact, fluctuating jaundice or intermittent jaundice is so characteristic of choledocholithiasis. Serum alkaline phosphatase and GGT both will be raised. There will be mild elevation of AST and ALT. So coming to the investigation, the imaging investigation, you can do abdominal X-ray, but only 10% of the gallstones are radio opaque. You can, however, the first investigation is you can do an ultrasound abdomen, but it is very ineffective to pick up a CBD stone. However, if you do an ultrasound, they can say whether the CBD is dilated or not. If CBD is more than 1 centimeter, then you can do the MRCP or ERCP. So MRCP is the best non-invasive diagnostic investigation, whereas ERCP is the gold standard investigation because it is not only diagnostic, it is therapeutic also. You can do ERCP stone extraction. You can also do CECT. This also can pick up the CBD stone. You can also do endoscopic ultrasound that can pick up the CBD stone and in case if there is a mass, you can also take a biopsy. So here you are seeing three pictures. The first one is ERCP, where you are seeing this is the endoscope. After cannulating the common bile duct, they have injected the dye. You are seeing multiple stones, the black shadows, one stone here, another one here, and there are so many stones in the lower part of the CBD. CBD is also dilated. It should be more than 1 centimeter, the diameter. So this is very diagnostic of the choledocholithiasis. In the second film, because in this ERCP, this is not only diagnostic, you can go ahead, if you find stones in the common bile duct, you can go ahead, do a sphincterotomy, use either Domia basket or balloon, you can extract these stones. Whereas in the second film, you are seeing MRCP or magnetic resonance cholangiopancreatogram. This is a non-invasive technique and it is only diagnostic. You cannot do any therapeutic maneuver. And the third one is the endoscopic ultrasound. This also you can use where you will attach the ultrasound in the tip of the endoscope, and there will be a radial ultrasound beam will be going there like this. So this is the stone, this is the common bile duct. You are seeing the stone there. Proximal to that there is distended common bile duct. This is what you are seeing in this film. This is the scopy and this is the ultrasound. You are seeing this is the common bile duct. This is a collapsed common bile duct, and proximal to the stone obstruction you are seeing the dilatation, and here you are seeing the stone also. And if you are seeing any mass in the in the common bile duct, that is cholangiocarcinoma, you can also take a biopsy using this endoscopic ultrasound. So coming to the treatment, suppose if the patient is not having any cholangitis, you can do ERCP, do sphincterotomy, and then you can remove the CBD stone either by using Domia basket or using a balloon. And this should be always followed by lap cholecystectomy or open cholecystectomy. Or you can do lap cholecystectomy with lap CBD exploration and removal of the common bile duct stone. In presence of cholangitis, this is an acute surgical emergency. You have to do decompression of the duct by using a ERCP, do a sphincterotomy, try to extract the stone. If you are not able to extract the stone, at least you can place a stent inside so that the infected bile will get drained. Or if it is not possible, you can do percutaneous transhepatic biliary drainage. That is, under ultrasound guidance, you can puncture the intrahepatic dilated biliary radicals with a needle, or you can put a catheter and you can drain the infected bile. You should do only if ERCP fail, then only you have to do this PTBD. If both ERCP decompression and PTBD decompression failed, then you can do open surgery. You can do decompression of the CBD by doing a choledochotomy, and then you can put a tube there. So here in the first picture you are seeing this is the endoscope. They have cannulated and they have did a sphincterotomy. So you have to cut this sphincter with this sphincterotome. Here you are seeing the picture. This is what they are doing it at 12 o'clock position. They are cutting the sphincter. Then after cutting the sphincter, you can put the Domia basket inside. You can catch the stone and then you can extract it. Or alternative thing is you can put a balloon inside, and if you pull it back and you put the balloon inside, inflate the balloon, and then you have to push it down. You are seeing already they have done a sphincterotomy also. This is the sphincterotomy. See, the stone has been extracted. You are seeing the stone here in the duodenum. So here you are seeing this is the Domia basket. They are removing the stone. Already sphincterotomy was done. They are extracting the stone from the lower part of the CBD. So in pre-laparoscopic era, we used to do open cholecystectomy, intra-op cholangiogram, choledocholithotomy, and then we used to place a tube. But nowadays, we are very rarely doing this procedure. If you place tube, you have to remove it after 10 to 14 days after doing a tube cholangiogram. If the patient is going to have missed, retain or residual stone. That means the occurrence of stone within 2 years following cholecystectomy. If tube is present, you can do a technique called Burhenny technique. That means the percutaneous stone extraction via the tube tract after 4 to 6 weeks using a choledocoscope, and this technique is called Burhenny technique. If tube is absent, then you can do the ERCP stone extraction. If it is a recurrent stone, that means the stone is there is presence of stone in the common bile duct 2 years after cholecystectomy. You can try the ERCP stone extraction first. If the duct is dilated more than 2 cm, then you must do either choledochoduodenostomy or transduodenal sphincteroplasty. So here you are seeing a tube cholangiogram where after injecting the dye you are seeing there is a residual stone here in the lower part of the CBD. So if the tube is present still, you can just remove the tube, and through that tract you can introduce a choledocoscope, and then you introduce a Damian basket, catch the stone and remove the stone through this tube tract, and this is called Burhenny technique. So how will you difference clinically the cholelithiasis, that is stone in the gallbladder, from choledocholithiasis, that is stone in the common bile duct? So cholelithiasis is stone in gallbladder. Choledocholithiasis is stone in common bile duct. Clinical features: cholelithiasis also can be asymptomatic, but it can present with biliary colic. Choledocholithiasis almost 50% are asymptomatic. Patient can present with right upper quadrant or epigastric pain along with features of obstructive jaundice. Complications in cholelithiasis are acute and chronic cholecystitis, choledocholithiasis, gallstone ileus, malignancy, and pancreatitis. Choledocholithiasis complications are cholangitis, both ascending and suppurative, features of obstructive jaundice, acute pancreatitis, and biliary cirrhosis. Diagnosis usually can be made by right upper quadrant ultrasound, whereas right upper quadrant ultrasound is not very sensitive in case of choledocholithiasis, so you must do ERCP. That is the gold standard investigation for choledocholithiasis, because this is not only diagnostic, it is therapeutic as well. Treatment: no treatment if it is asymptomatic. If it is symptomatic, that is if biliary colic or other complications, you can do elective cholecystectomy, that is lap chole. If it is choledocholithiasis, removal of the stone by ERCP, doing sphincterotomy, and removal of the stone either by Damian basket or balloon, and this should be followed by cholecystectomy, either open or laparoscopic. So this is the mind map for choledocholithiasis. So regarding the etiology, primary consists 5%, secondary is 95%. Clinical features: it can present in so many syndromes: biliary colic, obstructive jaundice, that is characterized by tea color urine, clay color stool, and pruritus. Chagas triad is that is called the ascending cholangitis. The Raynaud's pentad is when you are having suppurative cholangitis. There may be tender liver, but gallbladder is not palpable because of the Courvoisier's law. Because in a jaundice patient, if the gallbladder is palpably enlarged, that is not due to gallstone, so gallbladder is usually not palpable. If the stone is in the distal part of the CBD or in the common channel, patient may have features of acute pancreatitis. Investigation: you should do LFT, which will show raised total bilirubin and raised direct bilirubin, elevated alkaline phosphatase and GGT. Ultrasound abdomen will reveal the dilated CBD, that is more than 1 centimeter. You can also do CECT, or the diagnostic gold standard is the ERCP. This is not only diagnostic, it is therapeutic also. You can also do MRCP, but this is a non-invasive procedure. This is only diagnostic. You can also do endoscopic ultrasound. Complications are Because of the obstruction, there will be presence of white bile, biliary cirrhosis, suppurative cholangitis, that will go for septicemia, liver abscess, and pancreatitis. Treatment: if the patient is not having cholangitis, then you can try the ERCP stone extraction, and then this should be followed by lap chole, or you can do everything laparoscopically. You can do lap chole and you can do laparoscopic CBD exploration and removal of the stone. If the patient is having cholangitis, you can decompress the infected bile by doing ERCP, or you can go for PTBD. Or if both the procedures fail, you can go for open choledocholithiasis. If there is residual stone, that means the stone, presence of the stone in the common bile duct within 2 years post cholecystectomy, you can do Barheni technique if tube is present. If there is no tube, you can go for ERCP stone extraction. If there is recurrent stone, that means the occurrence of stone in the CBD after 2 years of cholecystectomy, post cholecystectomy. So you can try ERCP extraction, or if the duct is dilated more than 2 cm, you can go either for choledochoduodenostomy or transduodenal sphincteroplasty. So this is the diagnostic algorithm for obstructive jaundice. So you have to take the history, you have to find out whether it is a rapid onset jaundice or slow onset. If it is rapid onset, you have to examine the patient. If the patient is having a tender liver with elevated WBC, thick wall gallbladder with stones in ultrasound, that is a case of cholecystitis or Mirizi syndrome. If the patient is having non-tender gallbladder, normal WBC, normal walled gallbladder with stones and dilated bile duct on ultrasound, probably this is a case of gallstone in the bile duct, that is choledocholithiasis. If the onset is very slow, you have to do the examination, you have to try to palpate the gallbladder or any other mass. If the gallbladder is palpable, you can do ultrasound, CT, MRCP, ERCP or PTC. So that will prove this is a case of cancer head of the pancreas or periampullary carcinoma or cholangiocarcinoma. This is a slow obstruction. If the patient is having a tender liver, do hepatitis screen. If it is positive, this is a case of hepatitis. If there is enlarged liver, if it is smooth or irregular, you have to find out. If it is irregular, go for ultrasound and CT, and then you can do biopsy also. That will show the parenchymal or metastatic liver disease. So this is an extensive algorithm, treatment algorithm regarding choledocholithiasis. I request my viewers to pause this video and read this algorithm thoroughly, so that you can understand. I have told already all these things, but you pause the video and read it thoroughly so that you can pick up everything. So thank you very much for watching this video. So if you think that these videos are very useful, kindly share with your friends. Kindly subscribe to get notified regarding my latest uploads. Thank you once again for listening this video. Bye bye until I am going to meet you in yet another episode. Bye.